Assalamu alaikum. This is Dr. Haseed, and today we are going to discuss another very important topic regarding pain. And by the end of today's session, you will be able to define pain and how does it differ from the term nociception. Then we will learn different types of pain. How can we classify pain? This will be followed by nociceptors. What are nociceptors? What are different types of nociceptors and how do they act? And then we will differentiate between two types of pain pathways, the neospinothalamic pathway and paleospinothalamic pathway. Then we will discuss a little bit about pain modulation, and at the end of today's discussion we will discuss the components of the analgesia system in our body. So these are the learning outcomes for today's session. So let's begin. So pain is neither a disease nor a sign. Rather, pain is a symptom. So you must differentiate between a symptom and a sign. So pain is, in fact, one of the most common symptoms that you will experience in your house job. The patient can present with the complaint of pain in any region from head to toe. So the English neurophysiologist Sir Charles Sherrington, he described pain as the physical adjunct of an imperoprotective reflex. So pain is a protective mechanism. It's a warning sign that something is wrong. Rather, you can say pain is a blessing in disguise. According to the International Association for the Study of Pain, it is defined as an unpleasant sensory and emotional experience, which is associated with actual damage or potential damage. So, this is the definition by the International Association for the Study of Pain. Another term wrongly interchangeably used with pain is nociception. Although both these terminologies, pain and nociception, are frequently used synonymously, but there are slight differences between the two. Nociception is the unconscious activity induced by any harmful stimulus applied to sensory receptors. And how can we classify nociceptors? Nociceptors are the sensory receptors for nociception, and we have discussed the difference between pain and nociception. So nociceptors are the receptors for this sensation, and we can classify nociceptors according to the type of stimulus they receive or they detect. For example, if the type of stimulus detected by the nociceptors is of mechanical nature, such receptors are classified as mechanical nociceptors. Similarly, those nociceptors responsible for detection of temperature change, they are classified under the heading of thermal nociceptors. And these thermal nociceptors, they include both warm receptors as well as cold receptors. The thing to remember is that there is some overlapping between thermal nociceptors and pain receptors. Thermoreceptors and pain receptors, there is some overlapping. When there is extreme temperatures, for example, extreme heat or extreme cold, extremes of temperature, in such cases, the nociceptors are stimulated as well, and we classify such nociceptors as thermal receptors. And these thermal nociceptors include both heat sensitive nociceptors as well as cold sensitive nociceptors, and they are classified as TRP channels, where TRP stands for transient receptor potential channels. And these transient receptor potential channels, they are classified further from V1 to V4 and A1 to M8. So these are different types of thermal nociceptors which either detect cold sensitive changes or warm sensitive changes. So the thing to remember is that there is some overlapping between thermoreceptors and nociceptors. The next type of nociceptor is related to chemical stimuli, and these are known as chemical nociceptors or chemically sensitive nociceptors. So these are the three major types of nociceptors: mechanical, thermal, and chemical. And this classification is on the basis of the type of stimulus detected by the receptor. Some of the nociceptors, they are responsible for detection of any of these three stimuli, and they are separately classified as polymodal nociceptors. So polymodal nociceptors may respond to mechanical stimulus, they may respond to thermal stimulus, or even chemical stimulus. So according to some, the fourth type of nociceptor is polymodal nociceptor, which respond to any of the first three stimuli. So before we move on, there are some important points that you must note down. You must have read the Erlanger-Gazer classification of nerve fibers given in your Ganong's review in your first year. So you have to go back through the pages and review the table again. Erlanger-Gazer classification of nerve fibers according to the diameter and conduction velocity of the nerve fiber. So according to that classification, the nerve fiber can be classified under three major types: A, B, and C, where A has subtypes alpha, beta, gamma, and delta. So A delta fibers are the myelinated nerve fibers, and you can see the diameter is around 2 to 5 micrometer. So they have large diameter. Hence, you can see the conduction velocity is fast as well. And these are usually myelinated, enclosed by the myelin sheath. These myelinated A delta fibers are responsible for transmission of fast pain mainly. This is the main function of the myelinated A delta fibers, transmission of fast pain. We will discuss what is fast pain and what is slow pain later. So besides fast pain, these fibers are also responsible for transmission of sense of cold and crude touch. So if we compare the myelinated A delta fibers with the type C unmyelinated fibers, you can see the differences between the two. The diameter is relatively smaller in these type C unmyelinated fibers. You can see relatively smaller diameter, hence the conduction velocity is much slower. That is the reason we call these type of fibers as slow fibers, and they are responsible for transmission of slow pain. Unlike myelinated A delta fibers, which carry fast pain, cold, and crude touch, these unmyelinated type C fibers, they carry slow pain, sense of warm, sense of tickle and itch. So you must remember the differences between these two nerve fibers. Both are related to pain and temperature, but there are differences. Another feature that you must remember regarding nociceptors is that these receptors are non-adapting receptors. Adaptation is one of the most important feature of any receptor, but the unique property of nociceptor is that these are almost non-adapting. According to some, these are slowly adapting receptors, but the adaptation phenomenon is almost negligible in nociceptors. So we can surely say that nociceptors are non-adapting receptors. So you can remember the mnemonic that a delta plane is fast, but a taxi is slow. A delta nerve fibers for fast pain and C fibers for slow pain. So this is the classification of nociceptors. Now we will discuss the sense of pain. How can we classify sense of pain? So we can classify it as somatic pain or visceral pain. Somatic pain means that the pain is arising from all over the body, from the body. Soma means body. And if it is on the surface of the body, this is labeled as superficial pain. And if the pain is arising from deep tissues, this is deep pain. So somatic pain includes both superficial or surface pain as well as deep pain. Then we have the visceral pain. Visceral pain means the pain is arising from the internal organs of the body. For example, the internal organs of the abdomen, the stomach, the heart, the liver, the kidney. All these are visceras of the body. The thing to remember is that according to some sense of tickle and itch, they are also some sort of pain sensation. So we can include tickle and itch sensation to that list as well. So this is the simplest classification. There is another way for classifying the sense of pain, that is fast pain versus slow pain. And you can see there are multiple synonyms for each type of pain, whether fast or slow. Fast is of acute onset, slow is of delayed onset or chronic onset. Fast is the physiologic or good pain, where slow pain is the pathologic or the bad pain. Epicritic versus protopathic. So these are multiple synonyms for fast pain and slow pain. So pain sensation can be classified as somatic versus visceral, where somatic includes both superficial and deep. Or you may classify sense of pain as fast pain versus slow pain. So somatic pain, it includes both superficial pain and deep pain. Superficial cuts of with knife or superficial burn. Similarly, deep pain from the deep tissues, the fascia, the bones, the muscles, the joints. So pain arising from these areas can be classified as deep pain. Similarly, chest pain like pain of angina pectoris is visceral pain. Pain arising from the stomach, pain arising from the duodenum like peptic ulcer. Another example of visceral pain, intestinal pain, renal pain, all these are examples of visceral pain. So you can see multiple examples of superficial, deep, and visceral pain. these are the distinguishing features between the fast pain and slow pain. Fast pain, as the name indicates, is of acute onset, immediate pain or first pain or initial pain. Slow pain is of delayed onset. That is why it is also known as chronic pain or delayed or second pain. The type of nerve fibers for fast pain and slow pain, they are also different. A delta fibers for fast pain and unmyelinated type C fibers for slow pain. So these type of fibers, they respond to different type of stimuli as well. For example, fast pain is usually on stimulation of mechanical and thermal nociceptors, whereas slow pain is generally in response to stimulation of polymodal nociceptors. So we have discussed what are mechanical, thermal, and polymodal nociceptors. So how will the patient present? If the patient is presenting with fast pain, such pain will be described by the patient as sharp pin pricking sensation, like superficial cut with a needle. This will produce a sharp pin pricking sensation. This is easily localized and the patient will pinpoint to the site of pain where it is originating. On the other hand, another patient with slow pain will describe such pain that this pain is dull, aching in nature. And the patient, he or she, will not be able to localize the pain properly. So he or she may not pinpoint the site of origin of pain. Hence, the slow pain is poorly localized. So these are the main differences between fast pain and slow pain. Again, you can remember the type of fiber with the help of the mnemonic. A delta plane is fast, but a taxi is slow. A delta fibers for fast pain and C fibers for slow pain. A delta fibers are myelinated nerve fibers. C fibers are unmyelinated fibers. A delta fibers have greater diameter. C fibers have smaller diameter. A delta fibers have greater conduction velocity, and the conduction velocity for C fibers is relatively slow. Remember, conduction velocity is directly proportional to the diameter of the nerve fiber. Greater the diameter, greater will be the conduction velocity, and vice versa. Here you can see the summary of different types of pain sensations: somatic versus visceral. Somatic, if the pain is arising from the body, whether from the superficial or the surface of the body. Superficial pain, usually from the skin, or deep pain, usually from the deep tissues, the muscles, the joints, and the bones. Now, this superficial pain can be fast pain or slow pain. Similarly, deep pain is dull pain or poorly localized pain. Same is the case with visceral pain. So the pain arising from the internal organs of the body like stomach, gallbladder, intestine, kidneys, these are all dull in nature and poorly localized. Now, what are the causes of visceral pain. The pain arising from the internal organs of the body. What are the events that may lead to true visceral pain? The first and foremost cause is ischemia. And ischemia causes visceral pain. Why? Because this leads to formation of the acidic end products like bradykinin and proteolytic enzymes. And these agents, they tend to stimulate the pain nerve endings. The second cause is chemical stimuli. So any chemical stimulus may stimulate the nerve endings of pain. For example, the acidic gastric juice, if it leaks through the rupture of the stomach or the rupture of the duodenum, for example, in peptic ulcer, this will spread all over the gut and this will stimulate the pain fibers. So such stimulus is chemical stimulus. So ischemia may stimulate the nerve endings. Chemical stimuli like gastric juice may stimulate the nerve endings. Similarly, sometimes spasm of a hollow viscus may cause severe pain. Now this hollow viscus can be intestine, it can be gallbladder, it can be bile duct or ureter, or sometimes even blood vessel may be regarded as a hollow viscus. So contracture or spasm of any of these organs may stimulate the pain nerve endings. Then overdistension of a hollow viscus may promote ischemic pain. For example, overfilling of stomach. This will cause overstretch of the stomach tissues. So overdistension of viscous, hollow viscous may lead to ischemic pain. And the thing to remember is that there are some viscera which are almost insensitive to pain. Parenchyma of liver, the alveoli of lungs, these have unique properties that Allah has given, and these structures are almost completely insensitive to pain. So although the alveoli are insensitive to pain, but inside the lungs, the other regions like bronchi and the parietal pleura, they are extremely sensitive to pain in contrast. There are some insensitive viscera and viscera. So ischemia may stimulate the pain endings. Chemical stimulus like gastric juice may stimulate pain endings and cause visceral pain. Spasm of a viscus or distension of may stimulate the nerve endings and promote visceral pain. So these are the important causes of visceral pain. So we have discussed different types of pain, fast pain versus slow pain, somatic pain, including superficial and deep versus visceral pain. Another terminology frequently used in clinical setups is referred pain. So what is referred pain? The pain which is felt at a remote site, away from the site of origin. I repeat, any pain which is felt or experienced at a remote site, or you can say away from the site of origin, is called as referred pain. For example, if the pain of the lower abdomen is radiating and the site of referred pain is urinary bladder. Similarly, umbilical region, if this is the site of pain, the pain is radiating from the pancreas. Similarly, if the site of pain is at the tip of the shoulder, the pain may be radiating from the diaphragm of the body. Similarly, heart pain may radiate towards the central chest of the body, or sometimes classically the left arm and the left shoulder. So such pain is labeled as referred pain. The pain felt or experienced at a remote site away from the site of origin. Here you can see the areas of the referred pain. You can see the heart pain, the left side of the chest, including the left arm. This is the area for the heart pain. Similarly, you can see the pain of stomach. It is radiating towards the chest as well. And this is the side for renal colic, whether right or left kidney is involved. So any pain or painful stimulus felt at a remote site away from the site of origin is known as referred pain. And why this pain radiates to a different site in our body, this is the mechanism behind the referred pain. You can see the cut section of the spinal cord. The inner portion is the gray matter enclosed within the white matter, which is outside. And you can see the different types of nerve fibers entering the gray matter of the spinal cord. You can see these are the skin nerve fibers entering the gray matter, and these are the visceral nerve fibers. And both are making a synapse. These are the second order neurons, neuron 1 and neuron 2. So skin nerve fibers and visceral nerve fibers both are making the second order neurons, and this is the synapse. And the reason, the mechanism behind referred pain is that the branches of the visceral pain fibers here, they synapse in the spinal cord gray matter on the same second order neuron that are receiving the signals from the skin. That is the reason the referred pain is felt. So branches of the visceral fibers, they synapse on the same second order neuron on the spinal cord that are receiving the signals from the skin. So the viscera like heart, kidney or intestine will share a specific region of skin because the site of synapse on the second order neuron is the same. Now we will discuss few definitions which are important for your examination point of view. The first one is causalgia. Remember, all these definitions are related to sense of pain or abnormal pain sensation. So causalgia is spontaneous burning sensation felt after a long time in the area of previous seemingly trivial injuries. So this is known as causalgia, burning sensation felt after a long time in an area of seemingly trivial injury. Another term is hyperalgesia. Enhanced painful response to stimulus is known as hyperalgesia. In simple words, hyperalgesia means hypersensitivity to pain. And why there is hypersensitivity to pain? This is due to hyperexcitability of the pain pathways. And we will discuss what are pain pathways and what are the different types of pain pathways. Now this hyperalgesia can be primary in nature or sometimes secondary in nature. When we use the term primary hyperalgesia, this means there is excessive sensitivity of the receptors of pain. The receptors of pain receptors are extremely sensitive. The sensitivity is increased. Why the sensitivity is increased? Because the threshold has been lowered. For example, the sunburned skin area, it becomes extremely sensitive to pain. Why? Because there is release of histamine and prostaglandins which stimulate the pain endings. And when the pain threshold is lowered so that even non-noxious stimuli may produce pain, such condition is known as allodynia. So allodynia is painful response to non-noxious stimulus. Then we have secondary hyperalgesia. Hyperalgesia is hypersensitivity to pain. If the pain receptors are hypersensitive, this is primary hyperalgesia, in which the pain threshold is lower. Sometimes there is hypersensitivity to pain, but there is no lowering in the pain threshold. And this is known as secondary hyperalgesia. And secondary hyperalgesia, it results from any lesion in the spinal cord or thalamus. This causes the facilitation of the sensory transmission. Then the last definition, last terminology is reflex sympathetic dystrophy. Although the name is a bit complicated, but it is not that complicated. Reflex sympathetic dystrophy, in simple words, means that whenever there is sympathetic discharge, it causes stimulation of the nerve fibers in the skin. So sympathetic discharge in the injured areas. Whenever there is injury to the skin becomes thin, the skin becomes shiny, and there is excessive hair growth and sprouting of the nerve fibers. So in that case, if there is sympathetic discharge, there is altered circuitry of the nerve fibers, and the signal enters into the DRG of the spinal nerve, the dorsal root ganglion. So such discharge is known as reflex sympathetic dystrophy. So these are some important conditions which are related to abnormal pain sensation. All these are abnormal pain sensations: causalgia, hyperalgesia, whether primary or secondary, allodynia, and reflex sympathetic dystrophy. All these are abnormal pain sensations. Now we are going to discuss the most important topic of today's discussion, that is the pain pathways. And we have discussed the two types of pain: fast pain versus slow pain. Fast pain is acute, it is well localized, it is sharp. Slow pain is chronic pain, poorly localized, and it is dull. So for each type of pain, the type of nerve fibers are different. A delta fiber for fast pain, and type C unmyelinated fibers for slow pain. So Allah has made two separate pathways for fast pain and slow pain. And these pain pathways, they are the ascending pathways. And you must have discussed the anterolateral spinothalamic ascending pathway. Anterolateral spinothalamic tract. We discussed previously that lateral spinothalamic tract are responsible for transmission of sense of pain and temperature. And anterior spinothalamic tract are responsible for transmission of sense of crude touch. And collective term is anterolateral. So if we focus on the lateral spinothalamic tract, the lateral spinothalamic tract carries the sense of both temperature as well as pain. So pain pathways are a component of the lateral spinothalamic ascending pathway. We will not go into the details of transmission of temperature sensation today. We will focus on the transmission of fast pain and slow pain. And for fast pain, the pathway is neospinothalamic tract. Neospinothalamic tract is for fast pain. You can remember by the character of neo. Neo is fast. So you can see the type of fibers for fast pain are different. A delta fibers for fast pain. So we start the neospinothalamic tract, and like any tract, it starts with the stimulus, and the stimulus is fast pain. Any pinprick sensation, any cut with needle or knife will stimulate the receptors, and the receptors are the free nerve endings. The nociceptors are the receptors, and this stimulus will be detected by the free nerve endings, and the signals will be conducted by the A delta nerve fibers. And these A delta nerve fiber endings, they tend to release an agent for fast pain, and this agent is known as glutamate. So glutamate is released at the A delta nerve fiber endings, and then the signal will be transmitted to the dorsal root ganglion or the spinal ganglion. Here the nerve fibers will make a synapse, and the axons arising from the dorsal root ganglion are known as the first order neurons. The axons arising from the dorsal root ganglions, this is the first synapse, hence this is known as the first order neurons. Any neuron arising from the DRG is labeled as first order neuron. And then this signal is transmitted in the dorsal gray horn of the spinal cord. And here it makes a second synapse at the lamina marginalis or lamina 1. So if you remember, the gray horn of the spinal cord is divided into different laminae from 1 to 10. So lamina 1 is the lamina marginalis. So the neurons, the axons which arise from the dorsal gray horn of the spinal cord, these are the second order neurons, right? And then these second order neurons, they will cross over to the opposite side through the anterior commissure of the spinal cord. And this crossing over of nerve fibers to the opposite side, this is known as decussation. So they decussate and ascend as anterolateral spinothalamic tract. And most of the fibers, they synapse on the thalamus. And inside the thalamus, there are third order neurons. Remember, T for thalamus and T for third order neurons. So most of the fibers, they synapse in the ventroposterolateral nucleus of thalamus, also known as the ventrobasal complex. So some of the neurons, they pass through the reticular areas, and few of the fibers, they synapse with the posterior nuclear group of thalamus. But mostly it's the VPL or ventrobasal complex in the thalamus. And from the thalamus, the axons of the third order neurons, they arise. And these axons, they pass through the internal capsule and corona radiata, and eventually they reach the final destination and terminate at the somatosensory areas 1, somatosensory area 2, and somatosensory association area. Somatosensory area 1 is the area 3, 1, 2 according to the Brodmann's classification, whereas somatosensory association area is the area 5 and 7 according to the Brodmann's classification. So we have completed the neospinothalamic tract. Now we will discuss the slow pathway or the pathway of paleospinothalamic. So the stimulus in this case is slow, dull, burn, aching pain detected by the same receptors, the free nerve endings or nociceptors, and this type of signal is transmitted by the type C unmyelinated nerve fibers. Remember, in neospinothalamic pathway we have A delta fibers which are myelinated. In paleospinothalamic pathway we have type C nerve fibers which are unmyelinated. These unmyelinated type C fibers, they release substance P. Substance P is for slow pain. Glutamate is for fast pain. So again, the site of first order neuron is the same dorsal root ganglion from where the signal enters in the dorsal gray horn of the spinal cord. Instead of synapsing at the lamina 1 or the lamina marginalis, the paleospinothalamic pathway, they synapse at lamina 2 and 3. And these laminae, they are collectively known as substantia gelatinosa. And this is the site from where the axons, from where the second order neurons, they arise. So before ascending, they synapse for the second time within the dorsal gray horn of spinal cord at the lamina 5. So they synapse again at the lamina 5. So this is another feature of paleospinothalamic tract. So dual synapse inside the dorsal gray horn. Then comes the decussation, or you can say crossing over to the opposite side. They decussate through the anterior commissure and then ascend as anterolateral spinothalamic tract, just like the neospinothalamic tract. So the most important distinguishing feature from neospinothalamic tract is that the paleospinothalamic tract, they mostly terminate within the brainstem or within the thalamus. Only few terminate at the cerebral cortex. So unlike neospinothalamic tract, most of the fibers, they terminate in the brainstem and the thalamus. Only few of the fibers, they ascend to the cerebrum. So they either terminate at the reticular nuclei of medulla, pons or midbrain, or they can terminate in the tectum of the midbrain, or sometimes they terminate at the periaqueductal region of the aqueduct of Sylvius, and then they reach the thalamus. And from the thalamus, few of the fibers, they synapse in the ventrobasal complex. From there, the third order neurons arise and they reach the basal regions of brain and hypothalamus. So most of the paleospinothalamic tracts, they do not terminate, they do not ascend as far as till the cerebrum. So we have compared and seen the difference between the neospinothalamic tract and the paleospinothalamic tract. Now we are going to discuss what is pain modulation, also known as the gate control theory. So pain modulation or gate control theory, in other words, it means that inhibition of pain transmission is there whenever there is simultaneous tactile sensory signals. So if painful signals are stimulated simultaneously with tactile signals, the pain will be inhibited or suppressed. So stimulation of large A beta fibers, these are the tactile receptors. If they stimulate, they can depress the transmission of the pain signals from the same area of the body. And such inhibition is known as the local lateral inhibition of the spinal cord. For example, you must have observed that rubbing skin near the injured painful site is usually effective in relieving pain. Why rubbing relieves pain? Because stimulation of the tactile receptors, they inhibit the pain signals. And this is the concept behind the phenomenon of acupuncture. And you all know what is acupuncture, in which needle therapy is done and you are stimulating tactile receptors for suppression or inhibition of pain sensation. So if tactile receptors are stimulated, the pain receptors or pain signals are inhibited. So simultaneous stimulation of these two receptors causes inhibition of pain. And this is known as the pain modulation theory or the gate control theory. Now this is the diagram. You can see the gate control theory. So whenever painful stimulus is applied to any part of the body, so other receptors besides the pain receptors, they are also stimulated. So when all these impulses they reach the spinal cord, the fibers of the touch sensation, they send collaterals to the neurons of pain pathway. So in figure A, in the absence of input from the type C fibers, an inhibitory neuron is there. Here you can see this inhibitory interneuron, it suppresses the pain pathway. So no pain signal will be sent to the cerebrum or the brain. This is in the absence of type C input. In figure B, you can see there is a noxious stimulus. With strong pain, the C fibers stops the inhibition. So whenever there is noxious stimulus, the C fibers, there is no further inhibition from the interneuron. Hence, the signal is sent towards the brain. So no signal in the absence of noxious stimulus and strong stimulus in the presence of noxious stimulus. So whenever there is noxious stimulus, this inhibition by the inhibitory interneuron is stopped. Now in figure C, you can see simultaneous stimulation. We have noxious stimulus stimulating the type C fiber and touch stimulus stimulating the A beta fiber. So the idea behind gate control theory or the pain modulation theory is that whenever there is stimulation of the tactile A beta fibers, stimulation of these A beta fibers will tend to suppress the signals of the type C. So the noxious stimulus intensity has been decreased. So this has stimulation of A beta fiber has an inhibitory effect. This is local lateral inhibition of type C fiber due to simultaneous stimulation of A beta fibers. And the phenomenon is known as pain modulation theory or gate control theory. So we have defined the terminology of pain. We have classified types of pain, fast pain versus slow pain. We have discussed few abnormal pain sensations. We have compared the two types of pain pathways, the neospinothalamic pathway and the paleospinothalamic pathway. And we have also understood the concept of gate control theory. Now we are going to discuss the analgesia system of the brain and spinal cord. Analgesia system or the pain suppression system of the body. And there are multiple areas in our brain as well as in the spinal cord which tend to suppress the pain, and these components are collectively known as the analgesia system of the brain. And these areas, including the brainstem and the spinal cord, they are responsible for release of special substances like serotonin and enkephalin, where serotonin causes the local cord neurons to secrete enkephalin as well, and this enkephalin causes both presynaptic and postsynaptic inhibition of type C and A delta fibers. And we have already discussed the concept of synaptic inhibition, presynaptic inhibition, and postsynaptic inhibition already. We are not going into the details of synaptic inhibition. So this is the analgesia system, and the components include the periaqueductal gray region and the periventricular area of the midbrain and upper pons. So here you can see this is the periaqueductal gray region, and these are the periventricular nuclei. So these are the components of analgesia system. So besides these areas in the midbrain and pons, we have other nuclei located in the lower pons and medulla like Raphe Magnus nucleus, and the other nucleus is reticularis paragigantocellularis. Although the names are a bit complicated, but the concept is very simple. Raphe Magnus nucleus and nucleus reticular gigantocellularis both are located in the brainstem. Here you can see in the pons the nucleus of Raphe Magnus. So this is the second component of the analgesia system, and signals from here, they are transmitted via the second order neurons and then toward the spinal cord to the pain inhibitory complex. And the third component of the analgesia system is located within the spinal cord. We have discussed the multiple areas of brainstem, including midbrain, also known as mesencephalon, pons, and medulla. The last component is located in the spinal cord itself, that is inside the dorsal horn of the spinal cord. So this is the site where the analgesia signals can block the pain before it is relayed to the brain. So these are the components of the analgesia system. The periaqueductal gray region and the periventricular areas of midbrain and upper pons. In the lower pons and medulla, we have Raphe Magnus nucleus and nucleus of reticularis paragigantocellularis. And then if we come down towards the spinal cord, inside the dorsal horn, we have pain inhibitory complex. All these components, they are responsible for the release of enkephalin and serotonin, and the purpose is to suppress the pain, and these areas are collectively classified as the analgesia system of brain and spinal cord. So this is all for today's session. If you have any question, we have still a minute or two. You can write down the question. No more questions. All right. The take home message for today's session is that the fast pain is of acute onset. It is carried by A delta fibers. It is well localized. The slow pain is of delayed onset. It is carried by type C unmyelinated fibers. It is poor localized. Neospinothalamic pathway is for fast pain. Paleospinothalamic pathways is for slow pain. The pain can be also classified as somatic versus visceral, which includes both superficial and deep. So most of the slides were figures, flowcharts, and diagrams. Out of these 21 slides, hardly 5 of the slides were written as text. Most of the slides were in form of figures, flowcharts, and diagrams. Thank you. Allah Hafiz.